Okay, let us get into anterior shoulder dislocation. This is an important topic for the Australian Medical Council Part 1 exam. So let us go through it properly. Anterior shoulder dislocation is the most common type of shoulder dislocation you will see in clinical practice. It accounts for 95 to 97% of all shoulder dislocations. So if a shoulder is dislocated, it is almost always going anterior. Now let us look at who gets this. The peak incidence is in young males between 20 and 40 years of age. These are typically active individuals, sportsmen, footballers, gym goers. The second group is the elderly, particularly those with osteoporosis. In older patients, even a minor fall can cause a dislocation because their bones and supporting structures are less resilient. Now, here is an important number to know. The recurrence rate in males under 30 years of age is 50 to 80%. That means up to 4 out of every 5 young men who dislocate their shoulder for the first time will do it again. In contrast, those over 60 years of age have only a 10% recurrence rate. The reason is that older patients have stiffer, tighter tissues that resist redislocation. Remember this, a first-time dislocation in a young male carries the highest recurrence risk. This is extremely important for the Australian Medical Council exam. They will test your counseling approach based on age and recurrence risk. Now let us understand how this happens. The classic mechanism is a fall on an outstretched hand. In practice, this happens when someone falls and instinctively extends their arm to brace the impact. The force travels up through the hand, up the forearm, up the humerus, and drives the humeral head forward and out of the shoulder socket. The other common mechanism is forced abduction combined with external rotation. Think of a rugby player whose arm is caught outstretched and rotated backward during a tackle. That is the classic sporting mechanism. Now let us look at the associated injuries that occur when the humeral head displaces anteriorly. There are 3 important lesions you need to know for the exam. First, the Bankart lesion. This is an avulsion of the glenoid labrum. The cartilage rim of the shoulder socket gets torn away from the bone. This occurs in 80 to 90% of anterior dislocations. Think of the glenoid labrum like the rubber seal on a jar lid. Once that seal is torn away, the lid no longer holds. The joint loses its stability and redislocation becomes more likely. This is the primary reason why young patients have such high recurrence rates. Second, the Hill-Sachs lesion. This is a compression fracture of the posterolateral aspect of the humeral head. When the humeral head displaces anteriorly, it impacts the hard, bony rim of the glenoid, and this leaves a dent on the posterolateral surface of the humeral head. Think of pressing a golf ball firmly against a sharp countertop edge. You get a small but permanent indent. The Hill-Sachs lesion occurs in 60 to 70% of cases. Remember this, a larger Hill-Sachs lesion predicts a higher chance of recurrence. This is extremely important for the Australian Medical Council exam. Hill-Sachs lesion size influences surgical decision making. You do not need to memorize the full name of this lesion for the exam, but know it exists as a variant of Bankart lesion seen on magnetic resonance imaging. Now let us go through the clinical presentation. In practice, what you would see is the patient presenting with severe pain and an inability to move the arm. The arm is held in an externally rotated position, rotated outward, slightly away from the body. This is the key clinical finding. The normal smooth rounded contour of the shoulder is lost. Instead, there is a flat or hollow area where the deltoid muscle usually rounds out. On palpation, you can often feel the humeral head sitting anteriorly. just beneath the clavicle. Swelling and bruising may develop over the following hours, but they are not always present immediately. Do not rely on bruising to confirm the diagnosis. Now let us cover the neurovascular assessment. This is where most students make the mistake in the exam. The neurovascular examination is not optional. It is a mandatory part of assessment in every case of shoulder dislocation. The first thing to assess is axillary nerve injury. The axillary nerve runs directly below the glenohumeral joint. When the shoulder dislocates anteriorly, this nerve can be stretched and damaged. You test it by checking sensation over the regimental badge area. That is the lateral aspect of the shoulder over the deltoid muscle, which corresponds to the C5 dermatome. If sensation is reduced or absent there, this is axillary nerve injury until proven otherwise. You also test deltoid strength by asking the patient to abduct the arm against resistance. Loss of deltoid strength is another sign of axillary nerve injury. In most cases, axillary nerve function returns to normal after successful reduction. The second thing to assess is axillary artery injury. This is rare, occurring in approximately 1% of cases, but it is a serious complication that must not be missed. Always check distal pulses in the arm and hand. Check the color and temperature of the fingers. Cold, pale, pulseless fingers after a shoulder dislocation require urgent vascular surgery referral. The risk of axillary artery injury increases with age, delayed reduction, and forceful reduction attempts. The third point, and this is directly exam relevant, a complete neurovascular examination must be performed before and after reduction. Before, to identify any pre-existing nerve or vessel injury. After, to confirm improvement and to detect any new injury caused by the reduction itself. This is extremely important for the Australian Medical Council exam. If a question asks what is mandatory before and after reduction, the answer is a neurovascular examination. Now let us talk about investigations. The first step is always plain X-rays. You need three views: the anteroposterior view, the lateral view, and the axillary view. The anteroposterior view will often show an overlap of the glenoid and humeral head. Importantly, the light bulb sign that appears in posterior dislocation is absent here. We will come back to that comparison shortly. The axillary view is the most important for confirming anterior displacement. It shows the humeral head sitting anterior to the glenoid socket. That is the defining finding. Always look carefully for associated fractures as well. The glenoid rim fractures in up to 40% of cases. Tuberosity fractures and humeral shaft fractures should also be actively excluded. After successful reduction, magnetic resonance imaging is performed when there is clinical concern for labral injury. This confirms the Bankart lesion and assesses the Hill-Sachs lesion. Both are important for predicting recurrence and guiding the decision about surgery. If the fracture pattern is complex, a computed tomography scan is ordered for detailed bony assessment. Now let us go through management. Reduction should ideally be performed within 30 minutes to 2 hours of presentation. Delay leads to increasing muscle spasm, greater soft tissue damage, and more difficulty with the reduction. The principle is simple. The longer you wait, the harder it is to reduce. Before attempting reduction, there are three things you must do first. 1. Confirm with X-ray that there is no fracture pattern that would make reduction dangerous. 2. Document the neurovascular examination as it stands before you start. 3. Provide adequate analgesia and sedation. For analgesia, you use intravenous opioids combined with intravenous sedation, midazolam, 2 to 5 milligrams intravenous, carefully titrated. Inhaled nitrous oxide is a reasonable alternative in cooperative patients. Now for the reduction techniques. This is high yield for the exam. There are 4 techniques you need to know. Technique 1, Kocher, external rotation, then abduction, then internal rotation. This is the traditional method but carries a higher complication rate. It is generally not the preferred technique in modern practice. Technique 2, the Stimson technique. The patient lies prone on the stretcher. The affected arm hangs freely over the edge of the bed, and gentle gravity-assisted traction allows the muscles to relax and the humeral head to slide back into place. This is gentle, low risk, and well tolerated by patients. If you see in an exam question, the patient is placed prone with the arm hanging. That is the Stimson technique. Technique 3, the Cunningham technique. Gentle massage and muscle relaxation without applying any traction at all. Good outcomes and minimal risk. Technique 4, the Hippocratic method. This is historical and now outdated. Know it exists, but know that it is no longer recommended in modern practice. After successful reduction, here is what comes next. First, a post-reduction X-ray. This is mandatory. Anteroposterior and axillary views. This confirms the head is back in the socket and excludes any fracture caused during the reduction itself. Then, immobilization. The arm is placed in internal rotation with a sling and chest binding for 2 to 3 weeks. Remember this, anterior dislocation is immobilized in internal rotation. We will compare this to the other 2 types shortly. This is a common exam trap. From week 3, gentle physiotherapy for range of movement begins. Progressive strengthening exercises continue through week 6 to 12. For first dislocations in young males, make sure you counsel them clearly about the 50 to 80% recurrence risk. Conservative treatment is always attempted first. But in young active patients, early surgical stabilization is a reasonable discussion to have. For recurrent dislocations, surgical stabilization is indicated. The most common procedure is a Bankart repair, reattaching the torn labrum back to the glenoid rim. This restores the stability of the joint. These are the things the Australian Medical Council Part 1 exam will test you on. Make sure you understand the concepts, not just the facts. I will see you in the next one.